Hi, John. So training has been affected by COVID, just like so many other things. What do we know about it?
Well, it's been a big problem this year, as everybody knows. But just to put some figures on it, since lockdown started at the end of March, logbook figures overall are down by 50% across all specialties and haven't come back up to the pre-COVID levels or the year on year from last year. So there's been a big impact in logbooks, but of course across the board as well. And if you look at ARCP outcomes, we know that about 1 in 5 trainees are an outcome 10.1. So they haven't met the requirements for that training year and need to address something in the next year. About a third of ST7 trainees are on outcome 10 of some kind. So they either an outcome 10.1 or a 10.2. And so these are people going into the next year. And if you have another bad COVID second wave, like it looks like we're going to, then those requirements aren't going to be addressed. And people are going to move on to 10.2s and have their CCT put back through outcome 10.2. If you look at ST8, so those in the final year of training, we know that about 12% of trainees are on outcome 10.2, so already their CCT data has been impacted by COVID. So we've got to a position now where the front of the train is on the buffers, and we have to act now to stop the rest of the train careering into the buffers behind it. And trainees need trainers and high quality training more than they ever have done before.
And of course, we want trainees to meet the same requirements for certification as we always have done. We don't want to dumb this down at all. So what can we do about it? How can we maximize everything that we do for training?
So I think some general points really. There's lots of training encounters even in COVID times, and we need to get the absolute most out of every single training encounter. And that probably just overall boils down into 3 main areas. When you're having a training encounter, plan what you're going to do with the trainee and make it specific to what the trainee needs to do to get the most out of it. The second thing is let the trainee do it. Let them execute the plan that you've made and watch them do it and watch them closely. And just note in your own mind the things that you're going to say to them afterwards. And then thirdly, and probably most important of all, is give feedback. Give constructive, detailed feedback about what they've done and some pointers for how they're going to get better the next time they do it.
So this isn't really rocket science at all, is it? It's all about just doing what good trainers do all the time and making sure that we do it in every opportunity.
Yeah.
A lot of people are anxious about telephone consultations in clinic and how that might adversely impact training. What do you think about that?
Well, I think telephone clinics are absolutely ideal for training because there's no space requirements. You don't need an extra nurse to give you a clinic or an extra room. You just sit next to your trainee, and if you want to again beforehand talk about the case, what the trainee is going to say to the patient over the phone, and then you can sit next to the trainee and watch them do the whole consultation and listen to them their conversation with the patient, and then afterwards you can make a plan and debrief about the consultation, about the quality consultation and the treatment plan itself. And it's very, very safe. So if for instance, the trainee is going a little bit off message or the consultation not going as well as you might have hoped, then you can intervene straight away. So telephone clinics are an absolutely ideal place to train in outpatients.
Of course, you should tell the patient that you'll be listening in throughout the consultation when you do that.
Yeah.
And of course, if things are going well with the consultation, you could be doing a little bit of light paperwork on the side.
Don't want to get too excited in clinic.
And ward rounds, that's another great opportunity, isn't it?
Yeah, and I think that all it takes is instead of leading the ward round yourself, then step back a little bit and let the trainee lead the ward round. And depending on the level of the trainee and how quickly they go or how much time is available, that can be one patient, a bay, a ward, the whole ward round. So let them lead. You can stand and observe and intervene if needed, or back them up, or reassure the patient, etc., etc. But let them do that, and then again, feedback afterwards. Tell them what they did well, and tell them what they need to work on for next time.
And of course, in theatre, everyone focuses on doing the case, but there's an awful lot more about doing an operating list, isn't there, that we can get our trainees to do?
Yeah, from seeing the patients on the morning of the operation and observing their interaction with the patients, let the trainee lead the WHO briefing. At first, people automatically look at the consultant surgeon when they come into where the briefing's happening, but stand back and allocate the trainee to do the briefing and watch them do that. They're going to need to do that, and it's a great training opportunity. And then every single case that comes up is the trainee should be able to do at least part of it. Every case is a training case, and the trainee can do a small part of it or a larger part of it, depending on the case and depending on the level. But let no case go past with a trainee there without some training happening in that case. And then again, at the end, very important, give some feedback, give constructive feedback with specific points about how to get better next time.
And of course, we get many questions asked of us during an operating list, and we can direct some of those to the trainees to answer, couldn't we?
Yeah, what would you do? And take no alternative, what would you do?
Yeah, and that what would you do comes up in the MDM as well. We can get trainees to take the lead on some cases.
Yeah, I think the multidisciplinary meetings are an area where we don't train as much as we should do, but they're a fantastic opportunity. One, to help trainees interact with colleagues and present a case and summarise a case and the important parts of it. And then two, let the trainee make a decision based on their own knowledge. And so, you know, MDT decisions are made very quickly, but on knowledge that we all have and work with day to day. And it's a great way to see how much knowledge the trainee has to make informed decisions about patient care in whatever MDT you attend. And again, at the end, have a sit down and give some feedback.
Yeah, absolutely. And the last bit of work, of course, is emergencies. And we're probably already pretty good about giving trainees a reasonable amount of responsibility covering emergencies. But again, it's the giving of feedback, isn't it?
Yeah, and I think, you know, lots of us think let our trainees be much more independent in emergencies, but just maybe once or twice go and watch them clerk somebody, assess somebody, and talk through the decisions that they've made a little bit more on the ward round. And on the emergency ward round, there's another ward round there. Let them lead the ward round. Let them make the decisions. Obviously, be there to support their decisions and to help them think them through. And you know, again, and I can't say this enough, just give some feedback at the end.
So by using every one of these little opportunities, it can all mount up, can't it?
Yeah, I think if you did that, you know, you think of your working week and all the times you see a trainee, you made every single encounter a training encounter. You get a month's worth of normal training from a week of this much more by making most of the opportunities that you have.
It's a bit like in cycling, marginal gains.
Yeah. We'll have Dr. Dave Brailsford coming to help us with the training.
Okay, thanks very much, John.
Okay, thank you, Gareth.